Imagine a country where the projected death toll from preventable environmental and health crises could wipe out, well, more than double its current population within just 40 years. It sounds like something pulled from, I don't know, a dystopian novel, doesn't it? A future we only see in fiction, really. But for Nepal, according to the rigorous and frankly sobering analysis we've seen in our sources, it's not fiction. It's a stark, scientifically indefensible reality in the making. Welcome to the Deep Dive. Today we're unpacking a truly urgent and profoundly unsettling question for you, our listener. Can Nepal prove that fewer than 2 crore, that's 20 million deaths, will occur from environmental and health crises over the next 4 decades? Specifically between 2025 and 2065, our sources for this deep dive are, well, they're pretty comprehensive. We've got a foundational report detailing Nepal's projected mortality, alongside in-depth analyses of how other low-income countries are innovatively tackling massive health and education challenges, and we'll even be looking at the intricate, often paradoxical healthcare system in China.
So our mission for this deep dive is clear, really, and kind of twofold. First, we need to truly grasp the gravity and the scale of Nepal's projections. And then, crucially, we're going to explore what lessons the world, especially other developing nations, offers in building resilient health and education systems against truly significant odds. It's about finding concrete, proven pathways to, well, avoid such a dire future. Okay, let's unpack this for you. You might be thinking, how can these numbers be so incredibly high? I mean, really, what are the specific intertwined threats driving these, frankly, apocalyptic figures? And perhaps most importantly, what tangible actions can actually be taken to avert this catastrophe? We're going to dive deep into the data, connect the often hidden dots, and look for inspiration from global success stories that seem to defy economic constraints.
The report's framing of that central question is truly fascinating, isn't it? Can you prove fewer than 20 million deaths? It deliberately flips the burden of proof, which immediately highlights the immense urgency and the sheer weight of the current accelerating trends. It's not asking if these deaths will happen, but challenging anyone to demonstrate they won't, given the existing trajectories and scientific extrapolations. This shifts the conversation from sort of passive observation to active responsibility. We'll be seeing how these projections stack up against Nepal's current population. And then, as you highlighted, we'll move to explore how other nations are innovating and adapting, offering maybe a glimmer of what's possible, even with limited resources, if there's sufficient political will and strategic foresight.
So let's start right there with that central, unsettling question. Can Nepal actually prove that fewer than 2 crore, or 20 million deaths, will occur between 2025 and 2065 due to environmental and health crises? It's a question that demands an honest, data-driven answer, doesn't it? Not wishful thinking.
And based on the rigorous analysis presented in our primary source, the report's answer is not just direct. It's unequivocal. No, it cannot be proven. The stark conclusion is that it is highly likely the number of deaths will be more than 20 million, unless, and this is key, radical interventions are implemented immediately. It's absolutely critical for you, our listener, to understand that this isn't some speculative worst-case doomsday prediction built on, hypotheticals. Instead, this is a trend extrapolation based on very real-world baselines and current observable data, particularly regarding the compound annual growth rates for key mortality drivers. It is, quite simply, what the science suggests will happen if things continue on their present course, which makes the urgency of the situation all the more palpable and, frankly, terrifying. This isn't about what might happen, it's about what will happen without a fundamental shift.
Wow. That immediately grabs your attention and demands, well, further investigation. If the scientific consensus is that Nepal cannot stay under 20 million deaths, then what are the main specific drivers pushing these numbers so incredibly high? Let's break down the 3 primary causes of mortality identified in the report. Where do we begin? What's at the very top of the list?
We begin with a pervasive yet often underestimated threat: air pollution. It's a silent killer, really, and it's set to have a truly devastating impact on Nepal. The report details that from a current baseline of approximately 5,800 deaths per year, air pollution-related mortality in Nepal is growing at an alarming 16.9% compound annual growth rate, or KGR. For those unfamiliar, KGR signifies an exponential increase. It means the problem doesn't just grow, it accelerates year after year. If this trend continues unchecked, the projected cumulative deaths over the 40-year period from 2025 to 2065 are estimated to be between 20 and 25 million. What's truly astonishing and frankly a chilling aha moment is that even the lower bound of this single cause, 20 million deaths, already meets and even surpasses the entire 2 crore threshold that the report challenges Nepal to prove it can stay under.
Just one cause.
Exactly. This isn't just about lung issues either. It's a broad spectrum of severe health complications, including exacerbated respiratory illnesses, cardiovascular disease, strokes, and even certain cancers, all widely known to be directly linked to chronic exposure to poor air quality. We see this often in rapidly urbanizing and industrializing regions where environmental regulations and enforcement, well, they struggle to keep pace with development. Nepal, with its growing urban centers and reliance on traditional biomass fuels, unfortunately fits this profile perfectly.
Wow. Just one factor, air pollution, could potentially account for the entire projected crisis. That's a truly staggering thought. But then the report throws another major, perhaps even more insidious driver into the mix, antibiotic resistance, or AMR. Why is AMR, which often feels like a sort of silent, slow-burn threat in many parts of the world, projected to have an even more devastating impact in Nepal? What are we seeing in its current impact and projected growth?
AMR, or antibiotic resistance, is indeed a looming health catastrophe, and its trajectory in Nepal is even steeper and more alarming than air pollution. For those who track global health, AMR refers to when bacteria, viruses, fungi, and parasites evolve over time, rendering the medicines used to treat them ineffective. It means common infections become untreatable, minor surgeries become high risk, and routine medical procedures like chemotherapy become far more dangerous. Our sources show current annual deaths in Nepal from antibiotic resistance are around 6,400 per year. Critically, this figure is growing at an even higher CAGR of 18.1%. When you extrapolate that exponential growth over the 40-year period, the projected cumulative deaths from AMR alone are a staggering 30 to 40 million. This compounds the overall mortality projections by orders of magnitude beyond what we see with air pollution.
30 to 40 million.
Yeah.
Just from AMR.
Yes. The rapid acceleration of AMR in Nepal can be attributed to several factors common in developing nations. Widespread and often unregulated over-the-counter sales of antibiotics without prescriptions, insufficient public awareness about proper antibiotic use, poor sanitation leading to increased infection rates and therefore more antibiotic use, and inadequate diagnostic capabilities, which often lead to broad-spectrum antibiotic prescribing when not truly necessary. For a country with developing healthcare infrastructure, the exponential growth rate of AMR is incredibly dangerous because it erodes the effectiveness of standard treatments for common infections. This leads to prolonged hospital stays, higher medical costs, and increased mortality. The lack of strict regulation of antibiotic distribution is explicitly mentioned in the policy recommendations as a factor that needs immediate attention, underscoring its significant contribution to this explosive growth.
Those numbers are truly chilling, especially with AMR being such an invisible yet rapidly accelerating threat that undermines the very foundation of modern medicine. Let's shift gears now to climate collapse and Himalayan melting. When we think of climate change, many of us often picture distant melting ice caps or rising sea levels impacting coastal communities. But this report brings it right to Nepal's doorstep, connecting it directly to human lives in a very tangible and immediate way. What does the report say about its impact, both direct and indirect?
Well, while the direct death toll from climate collapse and Himalayan melting is numerically lower than air pollution and AMR, it's still profoundly significant and, crucially, acts as a dangerous multiplier for other crises. The projected cumulative deaths from these climate-related factors are estimated between 820,000 and 1.61 million over the 40-year period.
Which still sounds like a lot, even if less than the others.
It is. But importantly, these aren't just direct deaths from, say, extreme heat waves or sudden floods. The report elaborates on a cascade of indirect but devastating causes. We're talking about widespread famine from unpredictable monsoons and devastating crop failures, prolonged droughts leading to acute food and water scarcity, and the mass forced migration of communities fleeing uninhabitable or unsustainable conditions. The instability also brings catastrophic landslides triggered by erratic weather patterns and melting permafrost, and even the potential for increased conflict or war stemming from acute resource scarcity and population displacement. These numbers, though appearing smaller than the other two, represent a profound destabilization of society itself. Climate impacts don't just kill, they often dismantle the very infrastructure and social cohesion needed to respond to other health and environmental threats, leading to broader societal collapse and exacerbating the other mortality drivers we've discussed. They erode a nation's ability to cope with any crisis.
So if we take these three massive interconnected challenges, air pollution, antibiotic resistance, and climate change, what does this all mean when we put these factors together? What's the combined impact, according to the report?
When you combine these three primary drivers and make conservative adjustments to avoid any double counting or, duplication across causes, the report presents a staggering conservatively adjusted combined estimate. 60 to 70 million total projected deaths over the 40-year period.
60 to 70 million.
Yes. The report's conclusion here is blunt and uncompromising. The total cannot remain under 2 crore. It's unequivocally clear that Nepal's current trajectory is one of mass casualty on an unimaginable scale. But even this horrific figure isn't the whole story, as the report meticulously points out. It also highlights several additional causes that were not fully modeled due to the complexity or availability of data, but which are highly likely to push the figure even higher.
Yeah, there's more.
Yes. These include factors like female feticide, which is estimated at a shocking 50,000 to 100,000 annually, a general lack of access to essential medical treatment, which contributes an estimated 100,000 deaths per year, and suicides and accidents, currently accounting for around 20,000 deaths annually in Nepal. The report explicitly states that these alone, if added to the conservative estimate, could push the cumulative figure beyond 80 million over the 40-year period.
80 million.
This level of detail underscores the rigor of the statistical modeling approach, which relies on compound annual growth rate extrapolation based on real-world baselines for factors like AMR and air pollution, lending significant weight to these alarming projections. It's not guesswork. It's an extrapolation of existing, accelerating trends that paint a truly bleak picture.
This isn't just about individual death, it's about the very fabric of society, the future of an entire nation. What are the demographic consequences if these projections hold true? And we're talking about something far more profound than just mortality statistics. It's the potential for a complete unraveling.
Indeed. Our sources reveal that Nepal's total population is currently around 30 million people. The dire projection, if these trends are not radically altered through immediate and sustained action, is that by 2070, the living population could drop below 10 million.
Below 10 million from 30.
Exactly. This isn't just about the massive excess mortality from these environmental and health crises, although that's obviously a huge component. This projected demographic collapse is also driven by a confluence of other factors, like increasing infertility rates due to widespread health issues from pollution and disease, alongside mass migration as people flee increasingly uninhabitable or unsustainable conditions. And critically, the report mentions what it terms institutional collapse. This signifies a breakdown of the very systems that support society: the health and education infrastructure, governmental stability, economic systems, supply chains for food and water, and even legal frameworks, all dissolving under the pressure of such immense societal stress. This raises an incredibly important and chilling question for all of us. What kind of society, what kind of nation can truly remain when its population is so drastically reduced, when its most basic systems are in such disarray, and when the collective will to rebuild is itself diminished? It's a scenario that paints a picture of societal fragmentation, profound human suffering, and the loss of a nation's very identity, far beyond just the raw numbers of deceased individuals.
Okay. The numbers from Nepal are sobering, to say the least, and paint an incredibly grim picture of what could be an unimaginable future. But the report itself emphasizes that these outcomes are not inevitable. They depend entirely on radical interventions. So that's where we need to shift our focus. Let's turn our attention now to what those interventions might look like. We have sources that highlight how other low-income nations facing similar or even greater starting challenges have achieved remarkable success in health and education, proving that, economic constraints don't have to be destiny. These examples offer not just hope, but concrete strategies for building resilience.
Exactly. This raises an important question. If health and education are foundational for building societal resilience and preventing such a catastrophic future, what concrete strategies have worked elsewhere, especially in settings with limited resources, and how might they directly inform Nepal's urgent path forward? The experiences of these nations demonstrate that the blueprints for profound, transformative change exist, and they are not solely dependent on a nation's GDP. They often hinge on political will, community engagement, and strategic innovation.
Right. Let's start with healthcare. We often instinctively associate excellent health systems with wealthy countries, picturing, state-of-the-art hospitals, advanced technology, and vast budgets. But our sources highlight some truly inspiring examples from the global south, showing incredibly effective healthcare delivery despite significant financial limitations. What stands out to you in how these countries managed to deliver remarkably effective healthcare despite limited resources? What's their secret, really?
What consistently stands out across these success stories is the profound understanding that great healthcare doesn't have to be expensive, and the foundational belief that health is a human right, not a privilege. These countries aren't just throwing money at the problem, they're deploying innovative policy, fostering deep community engagement, prioritizing efficient resource use and placing a massive emphasis on prevention rather than just treating illness after it strikes. This strategic approach, which we can call primary care first or maybe a community-centric model, is a powerful recurring theme. Let's dive into some powerful examples, starting with Rwanda, a nation that truly transformed its health outcomes against incredible odds. With a GDP per capita of only around $900 after the 1994 genocide decimated its institutions and population, Rwanda achieved what many call a health miracle by drastically reducing maternal and child mortality rates.
How did they manage that with so little?
Well, they didn't build lavish hospitals. Instead, they implemented a community-based health insurance scheme called Mutuelles de Santé, which now covers nearly 90% of the population, significantly reducing out-of-pocket costs and making care financially accessible. Even more impactful, they deployed over 45,000 community health workers, CHWs, trained, often volunteer, individuals at the village level who deliver essential primary care services, from maternal health support to malaria treatment and health education. This decentralized, community-led model, coupled with rigorous, data-driven governance that tracks health indicators closely, has been truly transformative. It reveals a powerful insight. Localized, preventive primary care, even with limited resources, can deliver massive public health gains. Building on Rwanda's success with community-focused care, let's turn to Thailand, which took a different but equally effective route to universal health coverage. With a GDP per capita of about $7,000, Thailand achieved universal health coverage, UCS, in 2002 for a nominal fee of just 30 baht, or about $1.
Just $1. Wow.
Yeah. This scheme covers 75% of the population, while other public schemes cover the rest. Thailand operates on a model of public financing and public provision, meaning the government largely funds and delivers services. This allows for standardization, strict cost control, and equitable distribution of resources. They utilize a capitation payment model where hospitals are paid per registered patient, incentivizing efficiency and preventive care, as hospitals benefit more when patients stay healthy and require less intensive treatment. This approach has led to remarkably equitable and cost-efficient care, with stronger primary care networks compared to even some more developed nations. And for a model that's often overlooked but incredibly effective in its own context, Cuba offers fascinating lessons. Despite a GDP per capita of around $9,000 and decades of severe economic sanctions and limited resources, Cuba boasts life expectancy and infant mortality rates similar to the United States.
Which is incredible given the circumstances.
It really is. Their success is deeply rooted in neighborhood-based clinics, where a family doctor and nurse pair live directly within every community, providing continuous, localized, and highly personalized care to a specific population. They have a massive focus on medical education for the masses, training a huge number of doctors not just for Cuba, but even providing free education to foreign students. A core tenet of their entire system is preventative medicine, with frequent home visits, early screenings, and robust public health campaigns being standard practice to keep people healthy and out of hospitals. Beyond these, we see similar philosophies elsewhere. Sri Lanka, with a GDP per capita of around $4,000, provides free and universal public health with a strong primary care network and focus on preventative care, achieving health outcomes that rival much higher income countries. Ethiopia, with a GDP per capita of only about $1,000, has scaled up health access to millions through its health extension program, deploying over 38,000 government-paid health extension workers in rural areas and utilizing a health development army of community volunteers. These examples powerfully underscore that a strong, publicly driven, prevention-focused primary care system, leveraging empowered community health workers and low out-of-pocket costs, is a powerful recipe for achieving remarkable health outcomes even under severe resource constraints.
It's clear there are common threads here. Community-level access, a strong emphasis on prevention over reactive care, and a drive towards universal access, often with minimal out-of-pocket costs. But when you look at China's healthcare model, which our sources also detail, it seems to be such a different, complex beast. They've made massive strides in certain areas, yet also face unique, persistent challenges despite having far more resources than, say, Rwanda. What does its hybrid approach tell us about the limits, or perhaps the complexities of those common threads, especially at a vast scale?
China's healthcare system is indeed a fascinating and complex hybrid part-private, with a deeply embedded socialist legacy that has evolved through rapid capitalist reform since the late 1970s. It's an interesting contrast because while it has significant resources compared to, say, Rwanda, it struggles with a different set of issues, often related to scale and the tension between public and private interests. Its strengths are undeniable. China has achieved near universal insurance coverage, now covering over 95% of its massive population, which is a monumental achievement in scale over a relatively short period.
95% is huge.
It is. There's been massive investment in infrastructure, building thousands of new hospitals, especially after the SARS epidemic in 2003 served as a critical wake-up call. They also had notable public health success stories, like the eradication of polio and sharp reductions in infant and maternal mortality. And crucially, China is at the forefront of digital innovation in healthcare, widely using mobile apps for appointments, e-health records, and AI in diagnostics. However, despite these advancements, the system faces significant entrenched challenges. One of the biggest is overcrowded urban hospitals. Because primary care facilities in rural areas and smaller towns are often underfunded and perceived as lower quality, people with even minor ailments bypass local clinics and flock directly to major city hospitals.
So the primary care weakness drives that.
Exactly. This clogs the entire system, leading to long wait times, overworked staff, and driving up overall costs. This contributes to rising healthcare costs and high out-of-pocket payments, which stand at around 27% of total health expenditures, much higher than in countries with stronger publicly funded systems like the UK, where it's closer to 10%. There's also a drastic rural-urban divide in access and quality of care, with rich urban centers far outpacing poor rural areas. A problematic aspect is overprescription and profit motives, where public hospitals, which historically relied on drug sales for revenue, sometimes incentivize unnecessary tests or medications to boost their budgets, even if detrimental to patient care. Finally, China is grappling with a rapidly increasing chronic disease burden due to an aging and urbanizing population, placing immense strain on resources. China's ongoing reforms are actively trying to address these issues, aiming to strengthen primary care networks, improve electronic health records for better data management, reform profit-driven hospital models, and expand elderly and chronic disease care. China's experience highlights the struggle to balance scale, sustainability, and fairness, even with significant resources. It emphasizes the importance of a strong, well-resourced primary care foundation to prevent the entire system from getting clogged at the top. This is a critical lesson that countries like Nepal could critically learn from. Even with massive investment, if the foundational structure isn't right, if primary care is weak and profit motives are unchecked, challenges will persist and potentially exacerbate health inequities.
Okay, that makes sense. Now let's pivot to education, another cornerstone of societal resilience and national development. Just like with healthcare, our sources show that some of the world's poorest countries are building truly exceptional education systems that consistently punch above their weight on the global stage. How are they managing to do this, despite often having extremely limited budgets? What are their key strategies there?
This is where we see a powerful truth emerge. Excellence in education is not exclusively a function of GDP. Instead, it's profoundly driven by intense political will, innovative and often pragmatic policies, deep community involvement, and a pervasive societal respect for learning. These nations understand that investing in human capital through education is the most potent long-term strategy for development, social mobility, and ultimately resilience against future shocks. They see it as an investment, not an expense. Take Vietnam, for instance. Despite a GDP per capita far below most OECD countries, Vietnam consistently outperforms many wealthier nations on international assessments like PISA, that's the Program for International Student Assessment, particularly in math and science. Their 15-year-olds are scoring higher than many Western peers.
Really, that's impressive.
It is. Key features contributing to this remarkable success include a strong, centralized curriculum that heavily focuses on foundational subjects like math and sciences, a meritocratic teaching culture where teachers are rigorously trained, highly respected, and continuously supported, and the widespread distribution of low-cost but high-quality textbooks to ensure equitable access to learning materials. There's also extremely high parental involvement and a national culture that views education as the primary means of social mobility and national progress. Early strategic investments in universal primary education post-war laid a solid, equitable foundation for future learning. Cuba is another extraordinary example in education. Despite being economically and politically isolated for decades, it boasts nearly universal literacy, and its education indicators often rival those of much richer nations. Their system is built on free universal education at all levels, from preschool through university, including higher education. They maintain impressively small class sizes and one of the best teacher-student ratios globally, fostering individualized attention and strong student-teacher relationships. Teachers often live in the communities they serve, promoting community-based learning and integrating education more deeply into daily life. There's also a heavy, sustained investment in rigorous teacher training and continuous professional development, ensuring a highly skilled and dedicated teaching workforce. And uniquely, they even link health and education, with students receiving regular health checkups and meals at school, recognizing that healthy students learn better.
That integration makes a lot of sense.
It does, and Rwanda once again shines here, extending its post-genocide reconstruction efforts to education. After the 1994 genocide, Rwanda made education a core pillar of national rebuilding. They've achieved universal primary education, which is guaranteed by law and strictly enforced, and boasts one of Africa's highest gender parity rates in primary school enrollment, actively promoting girls' education. They've also embraced ICT-focused reforms, including the One Laptop Per Child initiative, to prepare their youth for a digital economy and equip them with modern skills. And robust community-based education oversight helps tailor learning to local needs and ensures accountability and parental engagement at the grassroots level. And we can briefly mention Kerala, a state in India which achieved nearly 100% literacy through decades of grassroots movements and consistent public investment in education. Its system emphasizes free, universal schooling with gender equity and decentralized management, fostering widespread participation. Another lower middle income nation, Georgia, implemented significant anti-corruption reforms in education and focused relentlessly on quality over mere expansion, aligning with European standards despite limited resources. These examples demonstrate that even without vast wealth, a clear vision, strong governance, and community support can lead to exceptional educational outcomes.
So the common threads across these education success stories are pretty clear then.
Yes, very clear. First, a strong political commitment to education as a national priority, ensuring it's seen as a vital investment rather than a disposable cost. Second, they demonstrate efficient use of limited resources with accountability, innovation, and strategic allocation at the core of their strategies. Third, there's significant community participation that reinforces learning both at school and at home, creating a supportive ecosystem for students. And finally, equity-focused policies are paramount, diligently ensuring that girls, rural populations, and the poorest households are not left behind, recognizing that widespread education is key to national progress. These nations prove that intellectual capital can be cultivated and harnessed even where financial capital is scarce, offering powerful lessons for a country like Nepal.
Okay, so we've journeyed from the grim, scientifically backed projections for Nepal to these incredible stories of resilience and strategic success from other nations, many of them also low income. It's a powerful contrast, really, moving from potential crisis to proven solutions. Now, the crucial question, how do Nepal's own proposed radical interventions, as outlined in the report, align with what we've just learned about global best practices in health and education?
This is precisely where the narrative shifts from crisis to actionable strategy. What's compelling is how Nepal's proposed policy recommendations directly mirror, in many ways, the successful strategies we've just highlighted from countries that have managed to build profound resilience against significant odds. These aren't just theoretical ideas, they are tried and tested approaches that have shown tangible results in challenging contexts. Let's break down the short-term recommendations, those ideally implemented within 3 years. First, the report calls to nationalize and strictly regulate antibiotic distribution. This directly addresses the escalating AMR crisis by exerting governmental control, drawing lessons from the need for strong public health governance and oversight to prevent misuse and ensure equitable access, rather than leaving it to fragmented, potentially profit-driven systems.
Right, tackling AMR head-on.
Exactly. Second, the recommendation is to declare a public health emergency. This is a critical step to galvanize public attention, catalyze national and international resources, and streamline bureaucratic processes, much like China's massive infrastructure investment after the SARS epidemic in 2003, which showed how a crisis can be a powerful trigger for systemic, rapid change. Third, to ban old vehicles and coal-based industry in urban areas, and to build a national air quality monitoring system. These are direct, immediate, and impactful actions against the air pollution crisis, signaling clear political will and a commitment to environmental health, a foundational element seen in all resilient societies that prioritize their citizens' well-being.
Okay, those seem very direct and targeted. What about the medium term?
Moving to the medium term, within 10 years, the recommendations include establishing universal healthcare and sanitation. This is a core feature of virtually all successful low-income health systems. We've discussed Rwanda's Mutuelles de Santé, Thailand's universal coverage scheme, Cuba's neighborhood clinics, Sri Lanka's free public health. The emphasis here would undoubtedly be on that primary care first and preventive approach to maximize impact with limited resources, reaching every citizen at the community level. Another crucial recommendation is to reforest 20% of degraded land. This is a direct, nature-based solution to combat climate collapse, contributing significantly to environmental resilience by sequestering carbon, stabilizing soil, and improving local ecosystems, aligning with the broader recognition of ecological health as fundamentally linked to human health. Furthermore, the report calls for developing evacuation plans for GLO, that's glacial lake outburst floods, caused by rapidly melting glaciers and wildfire hotspots, and to subsidize electric public transport. These are crucial climate adaptation and mitigation strategies that actively reduce environmental health impacts, protect vulnerable populations from immediate disasters, and reduce ongoing air pollution from conventional vehicles.
And looking even further ahead, the long term.
And for the long term, within 20 years, the report suggests climate reparations diplomacy with major emitters. This acknowledges global responsibility for climate change while strategically seeking external financial and technical support for Nepal's immense resilience efforts. It also recommends institutional reforms for resilience across health, food, and water sectors. This echoes the broad cross-sectoral commitment seen in educational successes like Rwanda's post-genocide rebuilding, where fundamental systems were reimagined from the ground up, and Kerala's grassroots literacy drive, which demonstrated sustained, deep-seated commitment. Finally, regional treaties with India and China for water and migration management are highlighted. This addresses crucial cross-border environmental and demographic pressures, reflecting the understanding that no nation operates in isolation, and broader, sustained international collaboration is absolutely essential for long-term resilience and stability, especially concerning shared resources like water and managing climate-induced migration flows.
It really brings home the report's conclusion that it is scientifically indefensible to claim fewer than 20 million deaths without a national transformation. This isn't just about tweaking existing policies, is it? It sounds like it requires a complete fundamental rethinking of how the nation operates, from its core values to its governance structures.
Absolutely. The sheer scale and multifaceted nature of the projected crisis demands nothing less than a fundamental shift, a true national transformation, as the report puts it. This isn't about incremental changes. It's about a complete reorientation of national priorities, resource allocation, and even cultural mindsets toward collective well-being and long-term sustainability. This echoes the strong political will and national commitment that characterize the successful health and education models we just explored. These countries didn't just implement isolated programs. They embedded health and education as central, non-negotiable pillars of their national development strategies, often driven by a post-crisis determination to rebuild better, stronger, and more equitably. The common threads we identified in both education and health sources: unwavering political commitment, efficient and innovative use of resources, deep community participation, and equity-focused policies. These are the radical interventions in action. For you, the listener, this means understanding that Nepal's current trends are a path, not a destiny. Proven, cost-effective strategies exist, but they require that powerful, sustained political will to be there and to be championed from the highest levels down to every community. It's about more than just policies. It's about a profound societal mindset shift toward collective well-being and long-term sustainability.
This has been a truly eye-opening and at times deeply sobering deep dive. To quickly recap, Nepal faces a truly daunting projection of 60 to 70 million, and potentially even over 80 million, deaths from interconnected environmental and health crises by 2065. This would lead to a devastating demographic collapse, with its current population of 30 million potentially dropping below 10 million by 2070. These numbers are primarily driven by the escalating exponential threats of air pollution and antibiotic resistance, tragically compounded by the significant, though indirect, impacts of climate collapse and Himalayan melting.
But as our deep dive has powerfully shown, this bleak future is not inevitable. We've explored concrete, inspiring examples from countries like Rwanda, Thailand, Cuba, and Vietnam nations that, despite facing immense resource constraints, have built remarkably effective and equitable health and education systems. Their successes prove that focused political will, smart and efficient resource allocation, a strong emphasis on primary care and prevention, empowered community workers, and a deep commitment to universal, equitable access in both health and education can yield remarkable results. These aren't just feel-good stories. They are the proven blueprints for the radical interventions Nepal so urgently needs.
This deep dive ultimately leaves you with a powerful and urgent question. If some of the world's poorest nations can achieve such extraordinary feats in health and education, proving that wealth isn't the sole determinant of well-being and progress, then what truly stands in the way of any nation, like Nepal, from charting a course towards resilience and a healthier, more vibrant future for its people? What political and societal transformations are you willing to advocate for in your own communities, and how might that understanding inform your perspective on global challenges?
Indeed, the sources highlight that while the challenges Nepal faces are immense, the blueprints for radical interventions exist and are, in many cases, already being successfully implemented in similar contexts around the world. The true test is not a lack of knowledge or effective models, but the capacity and, more profoundly, the resolve to implement them comprehensively, urgently, and with sustained political will. It's a powerful reminder that even in the face of overwhelming projections, human ingenuity and collective determination can defy the odds, reshaping an otherwise dire trajectory into one of hope, resilience, and renewed possibility for future generations.